Hi, and thank you for joining us for tonight's webinar, Bariatric Surgery in partnership with Prince of Wales Private Hospital. My name is Bertha, and I'm the CPD and Events Manager with Central Eastern Sydney PHN. Before we begin, I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise a continuing connection to land, water and community, and pay respects to elders past, present and emerging. Just quickly, Assessment has launched the Health and Community Service Directory designed to help people better understand the programs and services available to those in our region. For more information, you can visit the directory at servicedirectory.cespen.org.au. We have a great lineup of speakers today, and I would like to introduce our GP facilitator this evening, Dr. Georgia Rigas, who is the VMO-Obesity doctor and senior bariatric medical practitioner and founder and past chair of the RACGP Specific Interest Obesity Management Network. We also have Dr. Martina Gleeson, local GP and Health Pathways for Southeastern Sydney LHD. And I would like to introduce Ben Lewis, who is the Business Development Manager and GP Engagement with Prince of Wales Private Hospital. Thanks, Ben.
Sorry, good evening, everyone. My name is Ben Lewis. Thank you for joining us this evening for a fantastic talk on the bariatric metabolic surgery, what GPs need to know. Just something very quick overview. Prince of Wales Private Hospital is considered, one of the best surgical hospitals in New South Wales, renowned for its excellence in bariatric surgery. And some of the benefits of the bariatric surgery program include minimal wait times, holistic services, an expert team of some of the most experienced bariatric surgeons, and obviously experience in managing complex cases, as well as offering a wide array of the latest technology in laparoscopic and minimally invasive bariatric surgeries, which the list is on the screen there. I'd like to welcome and introduce tonight's speakers, Dr. Robert Gandy, Dr. David Links, and Dr. David Joseph. And tonight's topics are on the screen. If you'd like to learn more about tonight's, about the bariatric services at Prince of Wales Private, there's a QR code there that you can scan and access that information. So I'd like to introduce our first speaker for this evening, Dr. Robert Gandy, who's going to be speaking on who benefits from metabolic intervention and how do the non-surgical weight loss options stack up. Thank you, Dr. Gandy.
Okay, thank you for everyone joining us tonight, and thanks to our panelists and conveners for making this happen. I've only got about 20 minutes on a very large topic, so I'm going to get straight into it. So why are we discussing this topic? Well, there's a lot of development happening now in the world of pharmacotherapy, and I've been looking at including pharmacotherapy in my practice as a bariatric surgeon and bringing it into a more combined effort. It's estimated that by 2030, the business of pharmacotherapy is going to reach 100 billion a year, and there's lots of new research coming. There's lots of new companies joining the market and lots of new products. There's also lots of new players in the medical side of pharmacotherapy as well, with companies providing online services. And even in the UK now, the supermarkets are now prescribing drugs for weight loss. There's a lot of data, and the data is quite hard to pick through. And often what's presented to patients and doctors is only really the headlines. So we're going to try and pick into that a little bit more tonight. So I don't really have enough time within 20 minutes to discuss comorbidity management. There's a lot more data for this with bariatric surgery because it's been around for a lot longer. But there is data now coming about comorbidity modification only recently with patients with heart failure, for an example. But what we're going to concentrate on more is looking at costs, weight loss, longevity, and probably the thing that I want to speak about more than anything is managing expectations of patients, because it's very important. I can provide a bibliography of some of the sources. You may not agree with all the data, and I have looked at some of this data and standardized it so we compare one treatment to another. So the data you may see on the slides may not be what you see in all the studies and the headlines, but we tried to put it together so we can look at comparing different treatments. And in regard to expectations, when we look at the studies, what we're seeing with the studies is that we read the studies, but the patients don't read the studies. They tend to read the headlines, whether that's surgical or medical. So we know that bariatric surgery has been around a long time. It's now widely accepted that surgery affects enteropancreatic hormone regulation, as well as being restrictive and malabsorptive. And common pharmacotherapies are mimicking some of the effects that are observed in bariatric surgery patients. There's a lot of data. A lot of what I'm going to show is from the Australian New Zealand Bariatric Surgery Registry. And it is probably worth noting with registry data that a lot of the patients who fall off the registry are the ones who don't follow up to treatment and perhaps don't do as well. So we have to take that into account. There's been a lot of ups and downs with bariatric surgery over the last 50 years. There's been bad operations, there's been bad outcomes, and highly variably effective operations. But it's likely at the present that what the treatments we're offering at the moment are approaching the point where they're reaching the limits. And this is where it's important to potentially be looking at combining surgery and pharmacotherapy in the future. A lot of the data we're going to look at or we're using for this presentation comes from some very good, well-designed, randomized controlled data. They have very strict protocols. They're often performed in ideal circumstances, and they have significant proportion of the treatment they provide is with behavioral therapy and exercise and recording patients' outcomes. If we look at the primary outcomes, even on these two charts here, it's very difficult to interpret the results. As you can see, if you can see my pointer, they're all often at different endpoints. They're with different doses and different groups of patients. And what I've tried to do in some of the things I'm going to show you later is try and simplify this and try and apply it to patients. Of course, with data, you've got to look at the external validity. How does the trial reflect the real world? And what we've seen more recently is a lot of smaller papers coming up showing that perhaps the outcomes with some of the pharmacotherapy are not as good in the real world as they are in the trials. The question is, why is that? Well, the main reason at the moment is supply. Okay. All patients who are taking these medications have been affected by supply, but the other elements to it may be the fact that the support we're offering the patients is not as good, certainly in a large proportion of patients taking these medications off-label. Also in managing the side effects of the medications, particularly the gastrointestinal side effects. And the other part to it is patient selection. So we don't select our patients. In many respects, our patients select us. Just because our patients aren't ideal doesn't mean they don't deserve treatment, doesn't mean that they don't need treatment and shouldn't receive treatment. But often one of the issues we see is that we don't provide the same amount of support that they need. If they're outside of the recommendations of the trial, then they often need more support, not less support, and that's often at the moment what they're receiving. We're all guilty of remembering our successes and not remembering our average patients or patients who've had worse or less worse outcomes. But most of all, what we have to do is look at real world results and manage patients' expectations. So in terms of managing expectations, as I said before, the patients will often look at the adverts and the headlines and be attracted to particular treatments, whether it's surgery or pharmacotherapy. And we're probably as guilty as misleading our patients as well. If you look at the average weight curves from 2015, mean BMI for women is around 24 and for men about 26. This is not generally what people see when they're looking at the adverts. Patients often expect a lot more from their treatments than they're likely to achieve. And we're, as I say, often as guilty for misleading them. And we'll come back to this later. So if we look at some of the current therapies available, there's a number of traditional therapies for weight loss which are licensed, and a number which are used off-label as well. We're probably all aware of the top 5 medications that have commonly been used for weight loss over the last 10 years. The differences coming onto the market are largely the gastro or intestinal enteropancreatic receptor agonists, which have become well documented more recently. And just in terms of being clear, when we look at these slides, when we talk about Ozempic, we're talking about a 1 milligram dose. When we talk about Wegovy, we're talking about a 2.4 milligram dose, although it is accepted that some patients are using higher than the 1 milligram dose of Ozempic. And with Mounjaro, that's tirzepatide, and that's at the same dose as the weight loss licensed Zepbound, which is not currently coming to Australia. It's expected that the Wegovy will come to Australia within the next few months. So an important factor in all of this for patients is cost. We have a number of quite affordable drugs. Probably the best and underused one is metformin, which I've spelt wrong. And this is very cheap and accessible, can be accessed on the PBS, and is often now being used as an adjunct to other treatments, and actually works quite well in that fashion, with more and more data coming out. Wegovy pricing, when it hits Australia, is expected to be around the $500 mark, with Ozempic currently looking at around $130 to $150 a month. Endoscopic therapy, such as endoscopic balloon therapy and endoscopic sleeve therapy, don't have Medicare rebates at the moment. But bariatric surgery, although initially high cost, does attract a Medicare rebate and is usually priced within a 2-year treatment program with dietetics and surgical follow-up. We don't really have enough data in regard to pharmacotherapy about long-term efficacy and cost effectiveness. Because bariatric surgery has been around a lot longer, you'll see a lot more data regarding the effect on comorbidities long-term, cancer risk, cardiovascular events, remission of diabetes. And it will be some time before this kind of data is derived for pharmacotherapy, certainly the newer, more effective pharmacotherapy. But what we're seeing here on this slide is that despite the initial cost of surgery in the first year, over 20 years, there's a relative cost saving about $30,000 per patient, which is very significant. This is an NHS study. Sorry. If we go back to the weight loss studies, especially the GLP-1 and GIP studies, if we look at predictors of success, and the subgroups that do better than others tend to be female patients. They tend to be white or Asian patients. Patients with a lower starting HbA1c will achieve more weight loss. And interestingly, patients who on the studies are given a high-fat, low-sugar protein diet seem to do better than those that have larger amounts of sugar in the diet. Now, if you look down, the percentage is on the chart, which I have standardized. So those will be outcomes for at 1 year. They're not the highest percentage outcome achieved in the trials, but they're all standardized for around 1 year. As I said, with the bariatric data at the bottom, I have tried to standardize that down a bit because the bariatric registry data quotes higher figures. what we can see in this slide is that current pharmacotherapy in terms of tirzepatide seems to be currently outperforming endoscopic balloon therapy, bearing in mind that endoscopic balloon therapy has a maximum duration of 6 months. And the highest percentage weight loss with drugs like tirzepatide seems to be outperforming endoscopic sleeve therapy as well. We'll come back to this again. Interestingly, Saxenda and Ozempic are very similar drugs in terms of mechanism of action. Probably one of the main differences is the weekly versus daily dosing, which perhaps is beneficial in terms of getting more long-term therapy and not having missed doses. There are products coming to the market that will be once monthly injectable as well as daily tablet therapy as well, and we'll go back to that later. If we look at in terms of longevity, again, because bariatric surgery has been around longer, the long-term data is there, which we don't see with other therapies. But if we look at the top right there, we see that conventional diet medications and exercise and diet programs seem to all result in weight regain around the 6 to 9 month mark, with some coming back towards baseline quicker than others. We know now from the STEP trials that taking away patients' semaglutide results in fairly brisk rebound in weight, which is good to be proven that it's the drugs that are doing the work rather than the lifestyle intervention as part of the program. And it's also quite good for the company because it means that patients will need to continue taking their medications long term. Endoscopic sleeve gastrectomy does seem to, if you look at the graph in the top right, does seem to result in some moderate weight gain around the 9 to 12 month mark. And as we all know with bariatric surgery, that patients will regain weight, and I think David Joseph is going to talk about this later. But it seems to be around between the 18-month to 2-year mark that we start to see some weight regain, although it does seem to settle long-term at lower levels than the original when you compare to controls. So to try and help do this analysis, what I've done here is I've taken what we consider to be our average patient of average height. It would be a female patient, and look at different treatments for weight loss at different weights and points in BMI. So to start with, what we're looking at here is patients who are overweight approaching class 1 obesity with a BMI on one side of 25 and a BMI of 30. So if you look at the starting points and the end points, so we're starting with a BMI of 25 over here, you can see immediately that laparoscopic bariatric surgery is largely, not just largely, but inappropriate with patients that were likely to become underweight. With most of the conventional medications, you'll achieve some weight loss, but maybe not achieve much in the way of lifestyle intervention. Although with a patient who's starting at average weight, they're going to go back into the healthy weight category with most of these interventions. If we look at patients who are BMI 30, which is often the entry point for some of the pharmacotherapy trials, we see that we're achieving very good weight loss figures with patients getting back to or around average weight with most of these medications. And remember, this is at 1 year. This is not total weight loss, but at 1 year, we're seeing very good results. If we move on to our patients who are between class 1 and sort of class 2 to 3 obesity, we're seeing that even with a lot of the newer pharmacotherapy, this patient is unlikely to achieve what's considered to be a healthy weight. And even with endoscopic therapy, patients are going to be looking at BMIs in the range of about sort of 30 to 28. With bariatric surgery, even in this lower weight range patient, patients are going to be looking at achieving a BMI of around the national average, which is around sort of 26 in 2024. And I think this is sometimes where we're misleading our patients, because what our patients feel that they're going to get out of this is quite different from the reality. Now, there's a lot of things that we've taken for granted in this analysis. We're obviously looking at one patient with an average weight at different weight points. This analysis will be completely different for patients of different heights and likely different for males rather than females, where the results are not quite so good as well. But it's important to set expectations. And when we ourselves are dealing with patients who are in the obese or getting towards a super obese category, even with the current best weight loss treatments, the BMI is not going to get well below the 30 mark. So patients are not going to get complete resolution of their obesity. They may well get modification of their comorbidities and be much better off than the place where they started. But for many patients, this is not what they feel they should be achieving. And often this leads to a situation where patients think they have failed, and we should never use the word fail. What we're looking at here is the failure is perhaps that we're misguiding their patients, thinking that they're going to be down to a low BMI of 20, 22, and being essentially very fit and normal or even underweight. So I think this is a very important point for people who are doing doing weight loss surgery. I think it's a important point for people who are referring for weight loss treatment or starting medications, because what patients read in the highlights of the studies is not always reproducible. And even with the best current medical therapies in the very overweight patients, the results are not necessarily where patients need to be. But there are new things on the horizon. So currently, the best weight loss we see is with a double receptor agonist. There will be coming a triple receptor agonist, which includes a glucagon agonist. In early studies, we're seeing up to 24% weight loss, which is approaching that achieved with surgery. It does come with increased rates of side effects. Oral tablet medication of GLP-1 and GIP inhibitors will be coming on the market and already are available in the States for diabetics. This has the advantage not only of being a tablet, not an injection, but it's also a lot easier to produce, easier to make, and should solve some of the supply issues as well, and should be have better availability, especially to diabetic patients. There's a lot of other companies joining the market at the moment, looking at amylin, which is another peptide, which perhaps produces less gastrointestinal side effects and is better tolerated by patients. And then, as discussed before, there's monthly GIP antibody injections, which should improve weight loss given monthly rather than weekly. So in summary, and bearing in mind we haven't had a lot of time to discuss more into the sort of comorbidity side of things, what I'd like to see in the future is some of the pharmacotherapy companies concentrating more on weight maintenance rather than strictly weight loss. There seems to be a run at the moment to try and produce the best weight loss figure, when really one of the biggest problems we face both in the surgical world and the pharmacotherapy world is maintenance of weight. As we can see, current studies would suggest that these medications need to be ongoing. Personally, I think in the future, surgery and pharmacotherapy are going to coexist. I think there's early data to suggest even using metformin, both in patients using GLP-1 inhibitors and patients who are having surgery, improves outcomes. And I think this will be one combined area of weight management in the future. And the last thing that I want to say is that it's very important that we bring this all together in an environment where we can support the patients, because they do need a lot of support. Obesity is a very complex disease, and doing a single treatment and not supporting a patient is likely to lead to poor outcomes. And I'm going to end there. Thank you very much.
Thank you so much for that fantastic talk, Dr. Gandy. I'd like to introduce our second speaker for this evening, Dr. David Links, who will be speaking on how to work up a patient for metabolic surgery and how do we choose the right procedure. Thank you, Dr. Links.
So I'm talking about metabolic surgery, workup and choice of surgical procedure. What I've tried to do is tailor this talk around where you as GPs can intervene or act, and frame some questions that we should all ask along the way. So why do we bother working people up? And to my mind, there's a few reasons. We want to choose the right candidates who will benefit from surgery. We want to choose the right operation for people. We want to choose a safe operation. And we also want to try and avoid those bariatric surgery disasters that everyone has heard about. When we take some time to work people up, it also gives us time to set expectations. And then in doing that, we are able to provide sustainable and durable weight loss, improve comorbidities, or avoid things like stroke and heart attack. People will live longer, and their expectations will be matched with the outcomes, hopefully, and that will lead to a happy, healthy patient. How do I move on? Sorry. So the first thing I like to ask is, do these people actually fit the current criteria for metabolic surgery? And we all know the old 1991 guidelines for surgery, and that has actually been updated. So the latest guidelines from the IFSO and ASMBS in 2022 suggest that anyone with a BMI over 35, regardless of whether they have comorbidities and the severity of their comorbidities, will benefit from surgery, and there's medical evidence to support that. Certainly people with class 1 obesity, for BMI 30 to 35, who have other metabolic diseases, and the common one we see is obviously diabetes, should be considered for surgery. And interestingly, what came from those guidelines is that the BMIs should be a little lower for the Asian population who are considered obese at a lower BMI. I do wonder whether the guidelines for surgery will change in the Ozempic era, but that remains to be seen. There are some specific groups that I think we should consider. Certainly older age, we used to sort of deny people potentially surgery, certainly if they're over 70 or even 75. But I think we're starting to understand that really frailty is more important than someone's actual physiological age. And we know that frailty is associated with high rates of postoperative complications after metabolic surgery. In the adolescent group, there's clear evidence to support metabolic surgery. And we are using it specifically for people to bridge to renal transplant, for instance, complex hernia surgery in the obese. Joint surgery is safer if people have a lower BMI. And there is, previously we may have denied cirrhotics weight loss surgery, but there's some evidence to support that when they are compensated, and also for people with heart failure. And certainly super obese people, we should still consider surgery. So these are the recent ANSMOS guidelines giving clear criteria for surgery in adolescents. But I would suggest that this needs to be addressed in a unit who has experience with operating in adolescents and has the appropriate pediatric support to achieve a safe outcome. The next question I would ask is, do they have contraindications to surgery? And previously, as I alluded to, I think we had more contraindications, but things are loosening up as we have better understanding of what people can achieve safely. There are some absolute contraindications, and the obvious ones are untreated major depression or psychoses, significant eating disorders which have not been adequately addressed, drug or alcohol abuse, super high anesthetic risk doesn't justify surgery, and the inability to comply with ongoing nutritional requirements after surgery. This, to me, the take-home message I have here is that this is really just common sense. I think we can all tell reasonably quickly whether someone is well enough to consider surgery and whether they're going to be able to follow through with appropriate nutritional requirements long term. Clearly, there needs to be a multidisciplinary approach involving a bariatric surgeon, often a bariatric physician or GP with a special interest, a dietitian, a psychologist, and other specialists involved as needed. The next question I usually ask as part of the workup is, are they nutritionally ready to go ahead with metabolic surgery? And the dietitian has a very important role here. Obviously, the dietitian will assess their weight history over their life, their previous attempts at losing weight through diet and other options, and maybe where they've fallen down. The dietitian does have an important role in assessing micronutrients. So often, obviously, we'll order the micronutrient bloods, but they may have a significant role in advising around supplementation, particularly if there is micronutrient deficiency. And then they also have a very important role in educating the patient as to what their lifelong dietary choices need to be and habits need to be to enable them to achieve their goals that they have. They need to educate them on their pre-op very low calorie diet usually for 2 weeks before surgery, and also the surgical diet progression over that 4 to 6 weeks afterwards, where they're on thin fluids for a couple of weeks, puree diet for a couple of weeks, and then a soft diet for a couple of weeks. And every dietitian I know likes to push protein. I don't feel that there's one specific way to achieve success after weight loss surgery with dietary choices. And you can be a calorie counter, or you can provide solutions for patients which doesn't involve constantly weighing yourself or counting calories. Every patient responds differently. There's obviously a full set of metabolic bloods that need to be done pre-operatively, looking for micronutrient deficiencies, and then also looking for other causes of obesity, including, for instance, thyroid function, and assessing things like their diabetic control. The next question I would have is, are they medically ready for surgery? And often we need to consider referring people to other specialists for further workup. Certainly if they have significant cardiac risk factors, they may need clearance from a cardiologist. A lot of these people we operate on are diabetics, and we need to have these people with good diabetic control before surgery to lower their risk. And then we also need to adjust some of their medications, often around the VLCD, and also longer term, often they will have a lower requirement for the diabetic medications almost immediately after surgery. And this is usually involves either the endocrinologist or a GP with an interest. We should be screening people for things like obstructive sleep apnea, and often people will use the stop bang score. I think it'd be fair to say that most of us, and I'm often guided by my anaesthetist assessment, most of us are happy to operate on people with mild sleep apnea without referring them on for starting CPAP beforehand. But certainly if you have severe sleep apnea, there are benefits to having CPAP prior to surgery, and they also may need to be managed in the high dependency unit for that, at least that first night afterwards. And just something to note that you can use your CPAP machine straight the night after surgery. It's important with the medical workup to rule out other causes, including hormonal causes of obesity. The next question, are they mentally ready? I certainly don't refer all patients to a psychologist. I do talk about their readiness for surgery and some of the challenges that they've had, and we do have a group of psychologists that we work with when appropriate. And what a psychologist will do is assess their patient's readiness to engage and change with behaviours, assess whether they have realistic expectations, discuss some of the potentially hang-ups they've had through their life with their relationship with their weight, food, and the sort of things that might lead people to not achieve what they want to achieve or self-sabotage after weight loss surgery. Special things are things like shame at previous failed attempts, and often patients come in really fearing that the same thing is going to happen after surgery that has happened every other time they've attempted to lose weight. Psychologists obviously has special interest in addressing eating disorders such as binge eating, night eating disorders, and things like anxiety and depression. Often mild anxiety and mild depression can improve with weight loss surgery, but there are recognised instances where people's other psychiatric illnesses such as depression can actually get worse after surgery if they are unable to adjust. So there's clearly an important role for the psychologist in addressing these issues. One thing I would say is that if people have a lot of stuff going on in their life and they don't have the time to actually dedicate themselves to look after themselves and go through the process, I often will tell them to go away for 3 months, settle everything else down, and then when their life has settled down, come back and we can talk about proceeding with an operation. The next question I ask is, are they smoking? Because smoking is clearly a modifiable risk factor that can improve outcomes after weight loss surgery. We know long-term that smoking can lead to marginal ulcers in a gastric bypass. We know it increases the risk of bone fractures. And actually smoking doesn't have a significant effect on the amount of weight that people lose after surgery. Certainly, if you smoke within 12 months of surgery, it increases your risk of a leak at the time of the operation or in that perioperative period. That's for a sleeve and a bypass. It increases your risk of bleeding and it increases your risk of reoperation. Interesting, the data is a bit variable as to whether it actually changes mortality rates with surgery. But this is one area where I think you as GPs can be very helpful for us, is assisting with intervening for smoking cessation. And certainly the guidelines would say at least 6 weeks, but there is definitely benefit with ceasing smoking for longer than that. Interestingly, the rates of smoking recidivism are quite high after weight loss surgery, even if they've stopped beforehand. But the evidence would say that the longer you quit beforehand, the lower the risk of you restarting. One of the take-home messages I would have is that is smoking an absolute contraindication to weight loss surgery? I don't think it should be. There are some people that just will not be able to give up. We still know that there's significant health benefit after weight loss surgery in smokers. Certainly we would avoid a gastric bypass and a sleeve is preferable. But of course, if they can stop smoking, that would be the best outcome. Are they drinking alcohol? So we know alcohol is liquid calories and people tend to eat more when they're drinking alcohol. So we do encourage people to cease alcohol for at least 1 month prior to surgery. And certainly if there's a history of alcohol abuse, then we would advise longer than that. It's important to know that there is a recognised syndrome or relationship between weight loss surgery and increase in issues like alcohol abuse after surgery, and sometimes that's related to people transferring their food addiction across to other things like alcohol that they can control. We do advise people that they're likely to absorb alcohol a little quicker after surgery, so they need to take this into account. Other things that we think about before surgery is stopping some of the medications that increases the risk of DVT, and also doing a DVT risk assessment. Do they have a history of DVT, so they need to be on prolonged clexane after the surgery? So we do suggest ceasing the estrogen-containing contraceptives and HRT for a month beforehand. Some people we consider doing more anatomical tests, particularly if you have reflux. For instance, we might do an endoscopy, should do an ECG in some people who have cardiac risks, and we might do a CT scan if they've had previous abdominal surgery or any other concerns. We might do an ultrasound looking for fatty liver or gallstones as part of their workup. And then the final part of this is, I think there's some value in assessing the risk of the patient so that they can understand what their risks are. And there are some risk calculators to do this. And this is a typical patient, 51-year-old male, BMI 36, 105 kilograms with some hypertension and hyperlipidemia and some cardiac risks. And you can plug that into the risk calculator, and that will tell us in this setting, the top of the graph is an 8% 30-day risk. And we know that the blue lines are for a bypass and the red line is for a sleeve gastrectomy. So we know there's about a 4%, 3.5% risk of any complication after the surgery for this person. And there's about a 0.4% risk of a leak for a person like this. And you can assess all of those risks for 30 days. And then it will also give an estimate of weight loss. So we can see from here, the red line is a sleeve gastrectomy, and that patient after a year is expected to lose about 27-28% of their body weight. After a gastric bypass, they would be expected to lose about 33% of their body weight. So my take-home messages for workup is that it's very helpful when you refer patients to a bariatric clinic to include relevant past medical history and investigations in the referral, because every piece of information helps us make decisions around surgery and intervention. It would be helpful to encourage and assist with smoking cessation and alcohol cessation, and we should all be encouraging people to stick to their very low-calorie diet for the 2 weeks beforehand. So the second part of the talk will be on the choice of surgical procedure, and really this is to talk about balancing risk and understanding risk and benefit, and every patient sees risk differently. And that goes into the decision about which operation is appropriate. And I try to tell people, look, there's a risk of inaction and just continuing the path we're on. And what we're balancing is the risk of intervention, so surgery, the perioperative risk and longer-term risks, but also the benefits of surgery. And our job is to educate the patient about these risks and benefits, using medical evidence to give them an appropriate suggestion of what we think is appropriate. So often we're thinking about, is the operation safe for them? What does the evidence suggest we should be doing? What are their specific requirements and needs? Whereas the patient may be thinking other things. What are they reading on Facebook? What do they want to weigh 50 kilograms when they were 17? So we need to match up expectations between what their expectations are and what the likely outcomes are. The problem is that weight loss surgery is complicated. So there's lots of different interacting effects of surgery. And this is just one of the sort of tables or graphs that summarizes that. But I think we need to step away from all of the different interactions and how surgery works to just try and keep things a little more simple. How can we balance risk and reward for each patient? And we know that there's basically 3 or 4 operative options now. The sleeve gastrectomy is probably the most common option. The Roux-en-Y gastric bypass is the traditional bypass, and then a single anastomosis gastric bypass is basically taking a small pouch of the stomach, like a gastric bypass, and then hooking a limb of bowel up onto that so that food is delivered more distally in the small bowel. So the bypasses have a restrictive sort of effect, a malabsorptive effect as well as restriction, whereas the sleeve tends to have a more restrictive effect and affects hormones such as ghrelin. And then there's newer sort of more aggressive operations such as the SADI-S, which is essentially performing a sleeve and then dividing the start of the duodenum just beyond the sleeve and hooking that onto a limb of bowel more distally, which is a more aggressive operation, not done very often. So in broad terms, we know that the higher the expected weight loss and improvements with comorbidity resolution and things like that, the higher the short-term and long-term risk around the surgery. So the sleeve you might be expected to lose 25% of your body weight, and it has a lower risk, although the risks around surgery themselves with a bypass and a sleeve are about 3%. But the risk profile longer term certainly is lower with the sleeve than a gastric bypass. And then a SADI, you would expect to lose maybe 35% of your body weight, but again, there's an increase in risk. So we know that a sleeve has a lower risk of micronutrient deficiencies long-term and a lower risk of reoperation, whereas that risk is higher with a gastric bypass and even more than a SADI. For a SADI, we know that the intensity of follow-up can be a little less for a sleeve versus a gastric bypass. We know that a sleeve is a permanent operation and that puts some people off, but one of the benefits is it's technically an easier operation to do. And I think it's a benefit in that it's in continuity. You're not changing things around, whereas a bypass is potentially reversible. You could take it down and plug it back into the stomach, but it is technically more difficult, and it is replumbing things. We know that a sleeve has a slightly higher risk of weight regain, whereas the bypasses have a lower risk of weight regain. Specific factors that we should take into consideration, and these are the things I think that the nuances that we look at when we're deciding who should have what operation. Diabetics, we know that a bypass is going to be a better operation than a sleeve. Smokers, we know we shouldn't do a bypass on. Reflux, a sleeve can make reflux worse, whereas a roux-wide bypass is probably the gold standard for reflux, certainly if you also have a hiatus hernia. We know people that need NSAIDs should probably have a sleeve gastrectomy rather than a roux-wide gastric bypass because that increases their risk of a marginal ulcer. And what your bowels are like makes a big difference. If you're a truckie doing long haul and you have a bypass and then suddenly you're getting dumping syndrome and diarrhea all the time, that's a really big issue because you can't get to the toilet. So we know a sleeve tends to push people towards constipation. A bypass can tend to push people towards looser stools. And that's the end of my talk. Hopefully it was helpful.
Thank you so much for that talk, Dr. Links, particularly around some of the very practical information around the smoking cessation and overviewing the different types of procedures. Just going to quickly check. I'd like to welcome our third and final speaker for this evening, Dr. David Joseph, who is going to be speaking on managing issues pertaining to bariatric metabolic surgery in general practice, including common problems and weight regain. Thank you so much, Dr. Joseph.
Thank you very much, Ben. I'm just going to share my screen. I'm just going to talk about sort of post-op bariatric surgery, what GPs need to know and what are the issues with weight regain and should we be intervening for that. So thank you for the opportunity to talk. So patients had a sleeve or a bypass, and I think Doctors Gandy and Links have spoken about pharmacotherapy and surgical options, so you're familiar with that and probably from previous talks. So early post-operatively, patients will often have a bit of post-operative discomfort and some nausea, queasiness. That's particularly common after procedures, perhaps more so after a sleeve. Patients have some ongoing nausea. They'll often want to go home with some stronger antiemetic agents such as ondansetron. Most of us try and resist that because it can be incredibly constipating and they become almost dependent on it. It's probably appropriate that patients continue, if required, some analgesia for a week or two, but most patients can get back to pretty normal mobility activities with minimal discomfort within the first week. In terms of nausea, if it persists, we'll try and encourage patients to consider drinking smaller volumes more frequently and not to take large gulps or multiple portions at once. And we're happy, most of us are happy to intervene and discuss with patients if required in an early time frame. In terms of dealing with medical issues and comorbidities that often coexist in our bariatric patient cohort. Diabetes patients, most of them probably don't need to restart pharmacotherapy post-operatively. The vast majority are probably on monotherapy, such as metformin. For those patients who have more advanced, difficult to control diabetes, often on multiple agents with a higher HbA1c going into surgery, they may need closer monitoring and better intervention with yourselves, with dietitians, with endocrinologists. But again, usually that can be reduced within the first week to few weeks. So we'd very much encourage patients, and we'll often ask patients to go and see their GP within the first week to see how things are going and change doses. We'll usually have stopped the metformin or other diabetic medication when the very low calorie diet starts in preparation for surgery, and so we're usually pretty loath to restart. There can be a transient hyperglycemic period post-operatively due to the stress of surgery plus the steroid therapy given to reduce nausea and swelling post-operatively in the hospital setting, but that's usually settled upon discharge. Antihypertensive therapy, there's usually quite a rapid improvement, and patients, again, should probably have an early review with their GP to consider dose reduction or cessation. Patients can often develop postural symptoms of postural hypotension, dizziness. I'm not sure exactly what causes it. I have discussed this issue. It can persist for quite some time. It's almost like the whole vascular tone is geared to always being high, dependent on having a higher weight, and when weight comes off, it doesn't cope as well. So patients should be encouraged to sort of mobilize slowly and not get up suddenly. Sleep apnea doesn't really change early, and as Dr. Link said, we usually restart it within the hospital environment, often the night of surgery. That will continue, but again, a review should take place probably within the first few months, as pressures might need modification. Problems, complications that patients might come with a wound issue. There may be a bit of erythema. Often older patients have erythema around healing wounds anyway. There can be an infection, not common, but it's some simple oral therapy such as Keflex or flucloxacillin might be appropriate. Occasionally dehiscence, just from usually superficial. The actual incisions are very small, and it's rare to get a deeper dehiscence. Often just reassurance, a Band-Aid or a Steri-Strip will suffice. Thromboses are relatively rare. They can and do occur. They're usually associated with a pre-existing DVT history or a familial hypercoagulable state. All of us, like as with most surgical procedures, but particularly these, which have a supposed higher risk profile for DVT formation, patients will be getting calf compressors during surgery, intermittent calf compression, which will continue in the hospital environment, as well as Clexane. Most patients will not be discharged with Clexane. There are some clinics that do discharge 2 weeks or so of Clexane daily therapy on a prophylactic basis for patients with a weight over 150 kilograms, in the belief that those patients will have a high risk profile. We don't do that. We'll only do so with a proven history of DVT or the familial risk. Fortunately, portal systemic thromboses are rare. They will present with a out of proportion abdominal pain, nausea, often in the first week to 2 weeks after surgery. There's probably multiple risk factors and etiological factors at play. This is most often from an unrecognized familial hypercoagulable risk. There may be patients who are on oral contraceptive pill or smokers, and associated factors may include periods of dehydration. Technical factors within surgery, such as when performing a sleeve, we know from other procedures that if you disrupt the flow through various vessels around the stomach, you can get a reduced flow through the portal vein. And that's actually used to modify inflow for liver transplants. We can actually ligate a splenic artery and reduce portal inflow back to the liver. So if we're doing a sleeve gastrectomy and inadvertently someone's coagulated across the gastroepiploic artery, that can actually be a risk factor. So being technically good, making sure the patients are appropriately hydrated, and identifying risk factors. If it does occur, early recognition, early referral, there may be a role for anticoagulation therapy. Rarely are we in time for thrombolysis. Patients usually will come good, but it can be a very slow and long process, with hematology often involved in serial CT scans to ensure recanalization. Dehydration, nutrition is relatively, nutritional failure, relatively infrequent. Patients may certainly report that they feel dry or dehydrated. Biochemically, we often don't find any evidence of that, although we can understand that if patients are drinking under a litre a day of liquids, it may well be that they're feeling dehydrated. So we want patients to be drinking 1 to 2 litres a day at a minimum post-operatively. Most of us will want patients to be on track to be doing so before discharge. Bear in mind that there is an increasing push from both hospitals and some clinics to get patients out day after surgery or even the day of surgery, such as what's emerged in the United States of America on a cost-saving basis. So we may see the patients getting out really struggling a little bit more with liquid intake post-operatively, and there may be a role for earlier review, possible intravenous fluids early in a greater cohort of patients. Constipation is common early, a bit less common over time, and a couple of the factors at play are a reduced or altered intake of food, solids, liquids, as well as perioperative analgesia such as opiates and ondansetron, which is also constipating. So it's not uncommon that patients may not open their bowels for a week or so. We have a recommendation that patients maintain hydration, have regular fiber, which really only works if you're having at least 1 to 1.5 litres of liquids orally a day, and take Movicol if you require. We don't really like Coloxyl and Senna. It's good in a short-term basis, but patients end up becoming a bit dependent on it. Over time, bowel function tends to normalize. There's the occasional patient who has a reaction, if you like, to protein-rich fluids, that they may get the opposite of constipation, might have some loose emotions that usually settles down. Patients who suffer from gout, we may see a flare, and that's not uncommon, but I think that's important to note that, you know, an acute flare of gout in someone who's not normally on allopurinol may take non-steroidals for symptomatic relief and control, and we should just be aware of that in the early post-operative phase with sleeves, but particularly with bypass patients, that it does increase the risk of gastritis and stomal ulceration. So we'd probably want to avoid that. Colchicine may be a better choice for those patients. Early post-surgery leaks. I mean, Dr. Links showed that wonderful formula where you can kind of predict risk factors for leaks. It used to be about 1 in 100 patients. It's probably about 1 in 400 patients in lots of more recent studies suggested to be likely to have a sleeve leak. May require intervention. Again, will present with pain in the upper abdomen, fever, feeling unwell, may have shoulder pain. So, you know, a leak is usually proximal in the sleeve. You can get a subphrenic collection, which may well manifest with pain in the dome of the shoulder. Bleeds are less common post-discharge. They can occasionally occur while still in the hospital environment. You know, there's pretty of a tachycardia, discomfort. Rare to get melena or hematemesis, but it can occur. And you know, if the suspicion, contact the clinic, the surgeon, get the patient to the emergency department, and appropriate review. Most medications can be resumed post-operatively. We would tend to recommend, and we do prescribe a proton pump inhibitor for a month after a sleeve gastrectomy and a 3 to 6 month period following a gastric bypass to prevent stomal ulceration and allow things to heal. Most patients then don't require ongoing proton pump therapy for either procedure. As we discussed already, there's sort of an early modification in diabetes and anti-hypertension medications. Biological antimetabolites, so patients who suffer from conditions such as rheumatoid or psoriatic arthritis and methotrexate, we'd want to stop that a good few weeks operatively, and also usually cease it post-operatively as well. A lot of rheumatologists for some of the biological agents indicate that we could restart some of those things earlier, but if you actually review some of the medical literature, there's a lot of surgical papers suggesting that there is still an increased risk, and we'd try and avoid it. Obviously, that might mean some increased symptoms in those patients, and some symptomatic relief is appropriate. But usually within a month, we can restart all that therapy once healing has taken place. So in terms of how a patient would be expected to progress after surgery, within the first 1 to 2 weeks, they'll just be on a liquid-only diet, taking analgesia. If they've got a sedentary-only job, usually returning to work. There would be a period where they're on liquids and puree, and usually then at about somewhere between 4 and 6 weeks, patients will start on soft solid food, steamed fish, minced meat, steamed veggies, things like that. Supplements should commence probably within the first week, and there are chewable as well as tablet forms of good range of multivitamins. Protein supplementation should take place somewhere between 50 and 80 grams a day of total protein intake as recommended by the dietitian for our patients. Over time, the need for those multivitamin and protein supplements might diminish as quality of diet increases. Many of our patients actually have a deficiency in vitamin D, at least according to the laboratory values, and a lot of them will be on vitamin D supplementation after a clinic visit, but we'll continue that post-operatively. It's probably particularly important also to consider patients who have a malabsorptive procedure to be on vitamin D or calcium or combination therapy in the longer term, as there is evidence of a number of vitamin deficiencies in the longer term with bypass patients. Blood tests, we do sometimes see patients come back in the early post-op visit saying that they've seen their GP and they've had a whole range of blood tests. I guess it's not a problem to do it. There's probably not a reasonable indication in that you won't necessarily see any significant changes that early. We would recommend doing them every 4 to 6 months for the first 1 to 2 years of follow-up, and thereafter probably yearly, particularly for the bypass patients. And I think someone asked a question earlier during one of the other talks about what sort of blood tests might be appropriate to do on those interval periods. And so usual range of tests, but in particular, iron studies, B12 lipids, HbA1c, fasting insulin, vitamin D level. And just bear in mind that some of these tests, particularly like vitamin D, I think is only rebatable once a year. We often will do it more frequently than that. And some of the other tests that you might do, such as vitamins A, E, and K, we don't often test for. I've someone who actually has done a few SADIs, and that's quite a malabsorptive procedure, and I have tested for that. Patients will often be out of pocket. So that's things just to bear in mind. You may also end up looking at zinc and manganese and some other micronutrients that we don't normally test for. So they're the basic things that we would normally look at. In terms of what patients should be doing in terms of activity, mobilizing, walking around, they can walk, they can swim within the first 1 to 2 weeks. Return to work usually in the same week if they're able to, if they wish to, in a sedentary role. Some people have some sick leave owing and they might want to take a week or two off, and that's fine. For more physically demanding roles, it's probably appropriate to wait a few more weeks just for the incisions to heal up more than anything else. Patients should be encouraged to have the capacity to drink liquids through the day, as if you're often at work and not drinking through the day, it's very hard to catch up later and meet your liquid and nutritional requirements. Return to gym 4 weeks unrestricted. You could use a treadmill or an elliptical in the first week or two if you wish, but in terms of engaging your core abdominal musculature, probably wait a few more weeks. And then exercise is really encouraged. High intensity, short duration, high intensity is probably really good for modification of metabolism, but any activity is good, and a lot of patients do actually use a pedometer and report back how many steps they're taking, which is good, and it's better than sitting in a chair and not doing anything. Driving, there's no strict guidelines such as may exist after perhaps neurosurgery. They should have a few days off driving, at least 3 to 4 days. Some clinics and people recommend taking a week or 2 of no driving, but I guess it really depends on how the patients feel and how they're able to function. If you don't have any pain that may distract you, if you're not requiring any analgesia more than just Panadol, you're probably able to focus on appropriate driving. And a lot of people live alone or regionally and might have not a lot of alternatives to doing so. Air travel, there are guidelines that patients probably shouldn't travel 4 days after surgery. There's no actual data for that, but that comes from the airlines themselves. So particular Qantas and Virgin want an actual medical authorization to travel earlier than that. Patients aren't at risk of any increased problem in that period. Longer flights, I guess, consider a DVT risk, so patients probably shouldn't really travel long haul more than an hour or two in the first month or so, probably. Longer term issues, well, follow up. We really, I think all of us would recommend an appropriate period of follow up after the surgery, 1 to 2 years at a minimum. Frequent follow-ups every few weeks or months in that period, with a combination of both the clinic and GP. So that includes positive reinforcement of their journey, of their quality of life improvement, of review of medical comorbidities and dealing with issues and problems, checking blood tests, ensuring appropriate compliance with good nutritional intake. Occasionally, psychology may be required. I think we all selectively use psychologists. Some use of exercise physiologists. Some clinics have them on board, but an early resumption of physical activity is recommended, as I said. We think patients should have a regular GP. Unfortunately, some of our patients don't. Play an integral role in knowing the patient and also looking after them in the longer term. And we'll go on to talk a little bit about what is failure and what is weight regain. And I think that's important because it may occur later, and that's a really important place for intervention in the future. So longer term issues you might see in general practice, dumping syndrome, usually with bypass procedures. Some patients who've had sleeve report similar kind of symptoms. Some of our dietitians indicate whether the sleeve type of dumping is not real dumping, but it can be modified with better fiber intake. So the actual dumping that occurs, it's due to the fact that food can get through from the gastric pouch into the intestine pretty quickly and kind of overwhelms the capacity of the intestine to deal with the bolus of that type of food that's just entered. So it's normally with dense carbohydrates, particularly the sweet ones. It occurs a bit more commonly in Roux-Y gastric bypasses and single loop gastric bypasses, but a fair few patients will report too much sweet food and they'll get dumping syndrome, which is usually, diaphoresis, tachycardia, nausea, bloating, feeling pretty unwell. And so those patients need to be encouraged, and we warn them beforehand to avoid those kind of foods in large quantities. Obviously, it's not a component, or it shouldn't be a feature during the weight loss journey. But once they plateau, and patients may want to partake every now and then at a social function. Nutritional issues, particularly with the bypass and SADI procedures, there can be deficiencies in protein, in iron, particularly those patients, even with a sleeve, who are on longer-term proton pump therapy for some reflux symptoms. That kind of therapy reduces acid, which is essential for the absorption of iron. Reduction of global bulk of stomach volume, reduced B12 intrinsic factor complex, so less B12 absorption. There are now formulations such as sublingual as well as injections that can be used to replace folate. Consider that, obviously, if considering pregnancy. In terms of pregnancy, we do advise all our patients not to get pregnant in the first year after surgery. So to use contraception, and be aware that fertility increases fairly significantly with just a little bit of weight loss. So those patients who've had difficulty achieving pregnancy should perversely be told really to be extra cautious. And then after a year, usually a pregnancy can proceed without too much trouble, particularly with a sleeve. With a bypass, patients should be very much encouraged to get on with really good nutritional stimulation, and as though they were pregnant before they even try to conceive. Rarely there's a phenomenon of reactive hypoglycemia, particularly can occur usually in patients who've got some degree of diabetes. It's associated with carbohydrate intake and a dysregulated insulin response to some of that food entering the intestine very quickly, and they get profound hypoglycemia that's actually measured, and the occasional patient needs reversal of a bypass to manage it. Other things have been looked at, such as minimizer rings to sort of constrict the pouch to slow the food entering into the intestine, to shortening the length of the bypass have all been tried, but none of them work with a great deal of success, and it's pretty distressing to be hypoglycemic, and obviously life-threatening if you have a persistently low sugar. Reflux is more common in sleeve patients. Different report studies indicate that that's anywhere from 15 to 40% of 50% of patients. I guess the way sleeves have been done have changed over the two or three decades that they've been performed. They're probably not as tightly done and as before. You still get good weight loss, but probably a little bit less reflux. Reflux can be associated with certain food intakes, such as chili and tomato-based foods, but sometimes it just occurs frequently, just as many of your patients without any bariatric surgery might get reflux symptoms. May require prolonged PPI therapy, probably should be referred back to their clinic or a surgeon, gastroenterologist, for a review to assess if it is an ongoing persisting problem. And just in terms of, just to appreciate, Dr. Links did show a diagram indicating what a SADI is, which is a sleeve with a very short common channel bypass type procedure off the duodenum. And because the sleeve's still there with an intact pylorus, those patients can also get reflux. So they get the best of both worlds in terms of reflux and major nutritional challenges. So I think Dr. Gandy spoke very elegantly about, this whole concept. What is failure? And certainly from the patient's point of view, they'll see failure as anything where they're not achieving some ideal of, getting back in a bikini and looking good. Not all patients are like that, but there's certainly a cohort of patients that have probably an unrealistic expectation of what this is going to achieve and what it will give them. Many patients, particularly the larger ones, are really appreciative of any improvement in the quality of their life. Many of them have a fear of actual death, as well as health deterioration. So they're quite happy with any form of reasonable improvement in life, in comorbidity amelioration. 50% excess weight loss, anything over that is probably pretty good. We do talk about, patients getting 70, 80% excess weight loss within the first 2 years. There's often a little bit of weight regain, but anything over 50% excess weight loss in the longer term is probably pretty good. Another way of looking at how people do is looking at their comorbidity resolution. So they might get an improvement or resolution of diabetes, particularly with bypass procedures, sleep apnea no longer requiring, improved quality of life. People feel more alert, psychosocial well-being. That there's no real good documentation of seeing a patient who comes in and says, I can buy clothes now, I can, wipe my own bum, I can have a shower, I can just these big changes in quality of life that is not really measured on all these studies that look at comorbidities and BMI and things like that. And I think that's not to discount the big change you have in people's lives. And so in terms of what failure is, I think it's beholden to all of us, as clinicians, to talk to patients about what is a reasonable expectation of what an outcome should be. And it's an improvement in their quality of life. It's a return to some sort of normal function or an improvement in function. And they may well look better, but they shouldn't expect to there is no normal. And I think that's important. Weight regain will often occur after 18 to 24 months. There can also be periods where there's a weight loss plateau. And both of these things can be, I guess, attributed to some sort of behavioral failure. People returning to a form of pattern of nutritional intake, which got them in the problem in the first place, which is most of us, if we eat too much of the wrong food too frequently with less activity as we age, will probably gradually gain weight. And so I think explaining to patients what it is that's required long-term, it's a long-term disease. It's always at risk of coming back. There's no way they can return to their old life and expect not to gradually regain weight. So it can and does occur. The question is then, what would we or should we do about it? There are, of course, also patients who undergo, and they'll all tell us, and I think you're probably better at and dealing with them, particularly with the good relationship you may have with many of these patients, dealing with some of the psychological stressors that we all face. Patients often report, loss of loved ones or dealing with a loved one's illness, financial stress. All these kind of things return to some sort of disordered behaviors, whether it be smoking or alcohol or food. So they're all things to consider. Physiological, people talk about the wrong patient, the wrong procedure. We can have 20 patients and do a sleeve in all of them, and 3 patients just don't seem to lose weight in spite of everyone seem to be, yes, we're doing the right thing, and it just doesn't really. So I guess a physiological response to a procedure is different in everyone, and we do see that. So sometimes perhaps a different procedure might work better. So those patients that sleeve didn't work and they don't notice any change in appetite, the change in ghrelin, etc., doesn't really seem to do anything for them. And there we do see some people like that. Maybe a bypass might be appropriate. So what can we do for people who've failed to lose the weight that they'd wanted or they've regained? So reassurance to go through that issue that this isn't necessarily failure. This is what's changed in life. This is what's happened. And you can't and shouldn't compare yourself to all the people who've gone through the same journey. Behavioral intervention, there may be a role for ongoing psychological input, behavior modification, dietitian review, bariatric physician or surgeon to get involved again, to try to get to the bottom of paying attention to the patient, someone to listen and get involved in what changes can we make and what things can we stop that have crept back in And it's surprising the things that do happen that patients sort of almost don't acknowledge, but then become accountable to another clinician or GP, that then they might be prepared to change that again and at least stop the regain, even if they can't get any further loss. Interventional therapy, pharmacotherapy, and revision surgery. So, yeah, there may very well be a role for pharmacotherapy at stopping weight regain, at changing behavior. But again, it looks like this is not a short-term thing, just like we shouldn't view a diet as having any capacity for longer-term success unless you stay on it. So pharmacotherapy may only work if you can stay on it long-term. So that's something to consider. The correlation with subsequent cognitive therapy, intervention, dietitian, probably won't work as well as we'd hoped, but there may be a role for pharmacotherapy. And as better pharmacotherapy agents become available, there are things to consider. Revision surgery, that's a really hard one. Some bariatric surgeons just refuse to do revision surgery on the basis that the patients had their chance and they didn't succeed, they didn't follow the rules, and it's not going to do as well. And that's absolutely right, that patients as a cohort don't do as well as patients who've never had prior bariatric surgery. But there's certainly a fair group of them who will do better in terms of weight loss. But there are other indications or reasons for performing revision surgery as well. And here's one of them. We see less of these patients, but there are still some around, patients who've got bands or had bands in before. Now, those patients, it's not a great procedure, and I don't know that anyone really puts them in anymore in any great numbers. But a fair few of us are still taking them out, and I just did one today. So patients will often have a constriction in the upper part of the stomach. They'll get bad food behavior, and they get reflux and any sort of solid food. They'll get vomiting. They get a disordered food pattern with sort of pureed food, milkshakes. They have bad foods. Doesn't really result in adequate weight loss. If you scope them, they've often got a mega esophagus, an incompetent lower esophageal sphincter. Probably these patients shouldn't really proceed to have a sleeve, although some of them refuse to have a bypass, or they may be smokers, so you can't really do a bypass. So taking the band out, removing all the scar tissue and converting them to an alternate procedure is probably better than leaving the band in. So there's different things you can do. The bypass is probably a better procedure for these patients. A sleeve is more likely to result in worse reflux in this patient cohort. These patients may also require a hiatus hernia repair. Sleeves. So just appreciate that in Australia, well, in New Zealand, it's about 50-50 sleeves versus bypasses for the last 5 to 10 years. In Australia, for the last 10 years, it's been 80% or more of all patients having primary bariatric surgery have had a sleeve gastrectomy. So you'll see a fair few patients percentage of patients who have failed to lose the weight that they wanted or have regained their weight. So some patients want retightening of a sleeve, which I don't think is a really good option. It doesn't result in significant weight loss and just promotes increased risk of reflux and increased risk of a leak after revision surgery. So you're really looking at a changed physiological procedure. You've got going from a restrictive procedure to kind of a malabsorptive procedure, and so you're converting them to a bypass or a SADI, the single anastomosis duodenal ileal bypass. Now, the latter procedure, Dr. Links touched on, I've done about 50 of these, and I very rarely do them anymore. I don't love them. They don't fix those patients who've got coexisting reflux, of which they're patients who've got weight regain and reflux. And they result in some really difficult challenges in managing nutritional problems. They'll often only have a couple of meters of distal bowel performing all the nutritional absorption, and they've got major nutritional deficiencies that have to be dealt with. They don't get dumping syndrome because they've got an intact pylorus, but they will get frequent diarrhea up to 20 times a day. So it's not an ideal procedure. A bypass is actually a pretty good solution for these patients. But again, you're in a bit of a quandary for those patients who smoke. If you smoke or you actively or passively, conversion or primary or secondary operation to a bypass is really not advisable in any way. So indications for revision surgery: weight regain, sleeve to bypass or SADI, weight loss failure, revision of a bypass. So if 80% of patients are having a sleeve, 20% have had a bypass, and some of those patients get weight regain, even if they're less likely to have the sweeter, richer foods out of risk of dumping syndrome, they can still eat other food groups that might result in some weight regain. And we see it all around the world, and we have those patients as well. So it's a bit more challenging to come up with some solutions, and you can either reduce the size of the gastric pouch. We can put fixed rings around the pouch, which do have a role, but probably result in worse quality of life, and many of them need to be removed. Distalization procedures really essentially revolve around lengthening the amount of bowel that's been bypassed, which causes some additional significant nutritional challenges in the patient, and probably in lots of studies don't result in the kind of weight loss you might want to see. So there's no real great procedures. There's some very fancy procedures that are discussed at meetings overseas every few years. Some groups are reversing, as Dr. Link suggested, a bypass back to what the anatomy was meant to be, and then at a subsequent procedure performing a sleeve with SADI as an alternate procedure, and with some reasonable weight loss outcomes, but again, all those quality of life issues with loose bowel motions, nutritional challenges, failure, etc. So again, it goes back to the question, do they really warrant revision? It's not straightforward. There's higher risks of leak, of bleeding, adhesions. So I'm not sure that we should be doing revision in everyone. The evaluation of those patients, really, you want to make sure they're psychologically appropriate, that they're not going to go back and make the same errors as before, and many of them will.
Thank you, Dr. Joseph. I think we might have to wrap up the presentation there, just because we've got a little bit of a discussion to get through. So thank you so much for your presentation, and I will hand over to Dr. Rigas. Thanks.
Thank you to all of our speakers tonight. We've been collectively trying to answer some of the questions, or at least refer to some of the questions that have come up. I suppose I'm trying to put some things together for our fellow GPs on tonight's webinar. Could I'm not fussed who answers the question. One important question for GPs to consider is, given that diabetes is an indication for bariatric metabolic surgery, would someone like to outline which patients with diabetes are more likely to experience a better response to the metabolic surgery than others? Or if you want to turn it around, how soon should a GP be having that conversation with a patient living with diabetes and obesity, so they've got both? Because as we know, there is that window of opportunity. If a patient with burnt out type 2 diabetes presents for surgery, then they're not going to get as much metabolic outcomes. So what is the perfect time, or the preferred time for you as surgeons to be seeing a person with diabetes to maximize the chance of their metabolic response?
Yeah, I think there's good evidence that patients within the first 2 years of diagnosis of type 2 diabetes can expect a pretty good outcome in terms of particularly having a metabolic procedure such as a bypass at ameliorating the resolution of their diabetes. And as you say, Dr. Rigas, for the patients with longer term diabetes, they'll get an improvement perhaps, but they won't get resolution of the diabetes. So certainly within the first 2 years, I've had a couple of patients, and this is backed up by some studies overseas, SARDI, that really horrific procedure, it may be a little bit better as a diabetic procedure for the really poorly controlled diabetes. So we've had a few patients with very bad longer-term diabetes with limb amputations and sort of end organ damage that have actually had some improvement. So I wouldn't say it's impossible, but it's harder, and there's a price to pay on the other side with all those nutritional challenges.
Yeah, no, that's fair. And yeah, to concur with what you've said, yes, the literature suggests definitely in the first couple of years, but within 5 years of diagnosis, to have a favorable C-peptide level, as you know, ideally not to be on insulin and not to have any of the sequelae like the retinopathy, the diabetic foot complications, etc. Because we want to try to give patients the best chance to have an improvement. So that's pretty cool. One of the questions maybe one of your colleagues may want to answer is with pregnancy, would you consider having women who've had bariatric surgery and waited the minimum 1 year to be cared for by a midwife, an obstetrician? You're not fussed, or any thoughts or concerns in that regard, or whatever the patient prefers? Yeah.
I can talk a little bit to that. I mean, there are some fairly clear guidelines out there for management of patients who are pregnant and pre-pregnancy after weight loss surgery. I think certainly we would advise that people need to engage more with the dietitian, usually once a trimester, at least in that period. I don't know what the evidence is around whether they should have a midwife or an obstetrician specifically, but I think you certainly want a team working with you that has some experience with people after weight loss surgery. There's some particular issues that can come up. Certainly in pregnancy, we worry about things like gallstones as well being an issue, and we know that's a higher risk around having had a bypass or a sleeve. We know that people need specific nutritional excess or extra nutritional stuff, like more folate than even the standard folate recommendations around pregnancy. So I try to work with people's obstetricians and certainly pass on the guidelines, and there's some very nice diagrams in there saying these are the 5 things or 7 things you need to worry about around your pregnancy and afterwards. But there's good evidence that people can have a safe pregnancy after weight loss surgery.
Definitely. Yeah, no, definitely. Yes, and that's quite encouraging that there is some good data there. Having lost weight prior to conception reduces the risk of stillbirth, increases the chances of natural and IVF or assisted conception, etc. And I totally agree. There is some suggestion that it should be more obstetrician rather than midwife care, purely because women who have had a past history of obesity that has been treated by bariatric surgery would still be considered a slightly higher risk pregnancy, even if her BMI at the time she got pregnant was less than 30, because there is still that slightly increased risk of neural tube defects in the babies, hence the higher dose of folate, etc. But obviously the key is, to reiterate what you said, David, to make sure that we've got communication that's bidirectional, that the obstetricians that are involved are speaking to the bariatric surgeons and also speaking to the GP, and that the patient feels empowered, because especially in pregnancy, I've been pregnant in the past, but I've also helped manage many women in pregnancy after bariatric surgery. There's a lot of abdominal aches and pains that one can get, and it can be a little bit of oh, is it bariatric? Is it pregnancy? Is it other? So having that direct line to the bariatric surgeon or team going, look, we're thinking it might be this, but for example, with the gastric bypass, the Roux-en-Y, there is that small risk of a small bowel obstruction, which obviously is very devastating if not managed promptly. If someone's not on the phone speaking to one of you guys going, look, we're thinking it's probably this, but we thought we'd do due diligence and just ring you and say, what do you think we should do? Then we can ensure patient safety and good outcomes. So yeah, no, that were all the questions that I had from my end. Martina, have I overlooked any? There's another one that's popped up.
There's just another one that's come up that says post-surgery, if a patient is still struggling with hunger more than 12 months after their surgery, is there a role for reintroducing a GLP-1 agonist?
Can I answer because I've published on this? Sorry, sorry.
You know, this
That's
is why
the-
we have you here. You're an
Okay, and that's
expert
the
and a
only,
colleague.
and that is the only reason Robert said what he said at the beginning.
Yeah, exactly.
Okay, only because I'm yeah. So only because I'm passionate about this as well. So we've published, as have others. There is a role for using anti-obesity medication in patients who've had a partial response to surgery in that first year, but also after that first 12 to 18 months where most of the weight loss hopefully should have occurred, and those that regain weight down the track for a number of reasons. Given that obesity is a chronic disease, we're going to expect a bit of a lapse or relapse in the chronic disease. So the short answer is yes. Is it always going to be GLP-1 agonist? Well, I suppose we've got to look at the eating behavior and the phenotypes. You know, is it increased hunger? Is it reduced satiety? Is it, you know, a combination thereof, and then tailor the treatment to the eating behavior and the trigger, or the, you know, the root cause of the eating and the hunger, so to speak. Is it true hunger from, you know, the body needing something, hypothalamic, or is it emotional and stress eating that's more mesolimbic in origin? So yeah, one size doesn't fit all, as we all know. The response to any intervention is going to be different for one person and the next. However, it's important to involve the patient in the decision-making process and reassure them if treatment A, they don't respond to that, that's okay. There's a plan B and a plan C. So we're trying to do away with the shame and the stigma and the fear of, oh, I failed yet another thing again, like some of the other speakers earlier said.
Could I add one thing, Georgia?
Yes.
Patients who struggle with hunger often have reflux.
Correct. Yes.
It's reflux. And so if you're having a patient that's seeing in general practice who's telling you that they're always hungry and they're always snacking, and after weight loss surgery, a snack is a meal. You know, certainly if they haven't seen their bariatric team recently, they should come back and see us, and maybe even think about just trialing a PPI as a first treatment. That's the only thing I have to.
Yes, no, totally. That is, yeah, definitely. Same with, you know, the nausea after the rapid weight loss phase, it could be gallstones. You know, it's not always the pain. So yes, that's definitely an appropriate thing. Yes, thank you.
Just make the point that I think I know we're wrapping up, but all of us as surgeons, I think, are very happy to have people reach out to us. If you have any concerns about the, you know, combined patients or mutual patients, get on the phone, because we're always happy to know what's going on and hopefully contribute to their care if there's an issue. So don't be strangers.
And so I'm going to take a little opportunity to plug Health Pathways, because Sydney Health Pathways has, you know, information about complications of bariatric surgery and also management of people before, immediately after, and long term. And Southeastern Sydney also has those pathways nearly ready to go live. They should be available within the next month. And both of them also have pathways for helping you find a bariatric surgeon to help your patient if that's the decision that you and the patient make together. So yeah, just to reinforce the learning that we've already done tonight.
Great. Thank you, Martina. I think that was the last of the questions and comments, unless anybody has anything burning they want to throw in at the last minute. No, okay. I want to sincerely thank our speakers tonight, Dr. Gandy, Dr. Links, Dr. Joseph, obviously Georgina and Martina for facilitating tonight as well. Ben from Prince of Wales for organising the event. We will share resource for Health Pathways and also the specialist details, so you can get in touch with them if you need to. And thank you everybody for attending. Hope you enjoyed the session. Have a good night.
Yeah.
Good night.